Right, perfect. So welcome to this webinar and panel discussion on international perspectives on older adult social isolation and loneliness. My name is Amy Lee, the Senior Journal Manager for Frontiers in Public Health, and I extend a warm welcome to all of you here today. I'd like to kick us off by introducing you to our excellent panel of speakers. Professor Lenard Kaye is a professor of social work at the University of Maine. Professor James Lubben is Professor Emeritus at Boston College of Social Work and at University of California, Los Angeles, Luuskin School of Public Affairs. Dr. Ted Ng is an assistant professor at Rush University Medical Center. Professor Roger O'Sullivan is the director of the Aging and Development Division within the Institute of Public Health in Ireland and a visiting professor at Ulster University. Professor Matthew Lee Smith is a professor at the Texas A&M School of Public Health. So without further ado, I would like to invite the speakers to give us a presentation of this exciting project and to kick off a panel discussion after. Over to you, Len.
Thank you so much, Amy, and good morning, everybody. For the next 60 minutes, we're going to plan to share with you findings, conclusions, and recommendations that have emerged as a result of what is approximately a 2-year effort to assemble a global compendium of the most current research and scholarly inquiry into what we feel strongly is a matter of great concern, and that is the worldwide public health challenge being observed in the troubling levels of social isolation, loneliness, and disconnection experienced by older adults around the globe. Next slide, please. As an introduction, please know that the efforts of those of us making up the editorial team of 6 on this public health and aging research topic are grateful to the sponsorship and continuous support received from Frontiers in Public Health. They have become a leading global publisher of public health research and ensuring that it's accessible to the public. Joining me today in this webinar are 5 of the 6 co-editors on that project, as you heard. Let's move to slide 3. Slide 3 poses the question, the earlier slide, please. Yes, posing the question here is central to our webinar today. And simply stated, why did we decide to address older adult social isolation and loneliness, not only as a research topic, but also from an international perspective? Well, let me be clear. My colleagues and I are here today because we share a common concern, namely that it's critically important to understand from varying perspectives the growing fragility of late life relationships and the accompanying feelings of disengagement felt by too many older people. Next slide, please. We are convinced that this represents, in fact, an unprecedented and urgent challenge to human well-being, having major public health implications. We believe it's a complex matter as well to understand, since the risk of older adults living socially isolated and lonely lives can be influenced, as the research tells us, by a number of social, physical, environmental, psychological, cultural, and even economic forces. That multiplicity of influences, if you will, can be expected in turn to influence the ways in which individuals, families, and communities, and even countries mobilize efforts to address these threats to well-being, depending on whether it's going to be addressed primarily at a personal level, across entire communities, or even societally. What is increasingly clear is the consistent relationship social isolation and loneliness have been found to have in terms of their threats to personal health and well-being, including the increased risk of Alzheimer's disease and dementias, hospitalizations, morbidity, broadly speaking, mortality, poor health practices, greater risk of abuse, neglect, and exploitation, increased risk of alcohol and drug abuse, disrupted sleep patterns, disabilities, and even, I'll note, a greater risk of falling and succumbing to the common cold. Social isolation's association with reduced life has been equated with smoking 15 cigarettes a day. No wonder we feel the urgency to understand older adult social isolation and loneliness, better believing that in doing so is going to ultimately help us understand how to reverse its course as effectively and efficiently as possible. Next slide, please. We do know that having a robust social support network of family, friends, neighbors, and other significant individuals in later life apparently serves as an important protective factor. Each of us finding ways to feel that we are socially embedded with meaningful social connections is increasingly seen as an important strategy for reducing the risk of living socially isolated and lonely lives. And so, appreciating the different ways that people can feel connected to each other is an important piece of the puzzle, including, as you can see in this schematic, appreciating that social connectedness can be understood from structural, functional, and quality perspectives. Here I should emphasize that the quality of our social contacts appears to outweigh, in fact, the number or the quantity of social contacts in our lives. Let's move to the next slide. Before going any further, we want everyone to appreciate the depth of contributions that have been included in this special Frontiers Research topic collection. This topic and the resulting collection of articles were meant to help us achieve a more thorough understanding of the underlying causes and correlates of older adult social isolation and loneliness, as well as any promising programmatic strategies for bolstering older adult social and emotional health and community engagement. And we have perceived this throughout this project as intending to inform our understanding across diverse cultures, social systems, and populations. And what we received in the way of research undertaking around the globe did not disappoint. It met our expectations. Next slide. The final collection includes some 53 articles. This may be, as a result, one of the largest collections of current original research articles to be found on this topic. The vast majority of the research represents quantitative analyses of existing and cross-national data sets, including exceedingly large data sets from China, Europe, and the United States. We're pleased that the articles in the collection also represent the work of researchers who reside in 14 different countries and represent data reflective of older adults who themselves reside in 29 different countries around the globe. We do need to say that the research reports in this collection are not reflective of all countries, of course. We would have wanted to see representation from Russia, India, the African nations, and those in Central and South America. Those were not forthcoming. On the other hand, the ebook includes researchers from Australia, Canada, China, Germany, Ireland, Japan, New Zealand, Norway, the Republic of Korea, Romania, Sweden, Switzerland, the United Kingdom, and the US. Pretty impressive indeed. The data reflect research conducted prior to, during, and after the COVID-19 pandemic, and largely reports on older adults residing in the community rather than in long-stay care settings. It also includes research on older adults living with cognitive impairment. Much of the research we discovered is situated in theory, which drives the conceptualization of the issue and the research questions and informs the analysis. And we discovered the research submitted also utilizes a number of different measures to determine the presence and level of severity of social isolation, loneliness, and social disconnection among older adults. Next slide, please. So what have we learned from the research that has been assembled on this topic? Next slide. The research makes clear that across multiple nations, the fragility of late life relationships due to a sense of disconnectedness is an issue worthy of considerable concern. Weakened social ties are associated with multiple impacts, all of them negative, as described a few minutes earlier. The research also tells us there is as yet no simple formula for absolutely predicting which communities, groups, and individuals will experience particularly high levels of risk and the actual occurrence of social isolation and loneliness. Evidence, however, is quickly accumulating, indicating individuals and communities with high proportions of older adults of advanced age who live alone, who are living with a physical or functional disability or sensory loss, who lack instrumental support such as access to transportation, who are in poor mental health, facing critical life transitions, or LGBTQ plus identified individuals, those living on low income, with serious cognitive decline, and those with fragile social networks and connections are at greater risk. Research is also sending a clear message that solutions that can preserve and strengthen the integrity of our social lives are urgently needed. Next slide. The research in this collection has implications and raises important questions for future study. So I want to mention here in particular that we continue to ask the question, what interventions, programs, and policies will represent the most effective strategies at the individual, community, and societal levels for reducing the scourge of older adult isolation and loneliness? Secondly, are there preferred definitions and measures that should be used for assessing isolation and loneliness, such that different studies can more easily be compared and contrasted? Third, are we destined to live in an increasingly lonely and disconnected world, even as the pace quickens in terms of advances in communication and information sharing technologies? Fourth, what additional evidence do we still need to convince a more broad audience that social isolation and loneliness are indeed public health threats? Fifth, and this is really not a question, we argue we need to continue to arrive at a better understanding of the relationship between social isolation and loneliness in older adults in particular. And then finally, the sixth question, which certainly has worldwide implications, is this: is it time for a global strategy to address the scourge of social isolation and loneliness? We sincerely hope that this collection further sparks investigative efforts at comprehending and responding more fully to the deeply concerning impacts of social isolation and loneliness on older adults and the world in which they live. The research collected in this special topic compendium certainly drives home that point, and other research being conducted elsewhere is doing the same on a continuous basis. Next slide. So now we are going to move on to our panel. Four of the six co-editors for this special topic issue are here with us today. Happy to welcome James Lubben, Ted Neng, Robert O'Sullivan, and Matthew Lee Smith, who will be in brief fashion answering a number of questions that we feel need to be answered. Our panelists have been asked to respond with brief 3-minute or so responses so that we can address as many of the questions you see on the next slide as possible. Next slide. So let's begin right from the outset in asking the question, are there in fact different types of loneliness? And I'm going to ask Roger O'Sullivan to share where he stands on this.
Thank you, Len, for a brilliant overview. Really well done. So if we think about loneliness, and it's important to remember that loneliness is a very personal, subjective experience. And it's a difference between one's preferred and one's actual social and emotional connections. For me, there are three different types of loneliness: social loneliness, emotional loneliness, and existential. So in social loneliness, it's the experience of a perceived lack of social connections, whether that's in family, friends, neighbors, or the community. Emotional loneliness describes the absence of a significant other that you have an emotional connection with, a partner or a friend. Existential loneliness, that describes the feeling that you're disconnected from others and society. Even if you are surrounded by people, you may feel disconnected. For those people who studied sociology, this is what Durkheim talked about, anomie. As well as different types, it's important to think about different frequencies. So say transitional loneliness, that occurs at a time of change, like bereavement, retirement, maybe becoming a caregiver. Situational loneliness, that occurs during a particular situation, like say the COVID pandemic. Occasional loneliness, well, that describes that feeling that comes and goes, something that's just seen as being part of being human. But persistent, consistent loneliness is when you feel lonely all or most of the time. So that's really important. And just like pain, if you think about loneliness, just like pain, there's mild loneliness and severe or intense loneliness and different durations. So Len, that just shows that when someone says, that they feel lonely, it's important to understand, and is it loneliness or social isolation? What type is loneliness is it? What's the frequency? And how intense is that? Thanks very much. Thank you.
Thanks, Roger. That was very, very helpful. Let's move on to our next question, and that is whether loneliness and social isolation are indeed the same concepts. Jim, what do you have to say to that?
Well, they're cousins, but they aren't identical twins. So they are related constructs, but there are some important differences. And I'm actually going to read from a report that came out in January of this year, and I'll put the citation in the chat box later, from WHO. And this is Mental Health and Social Connection was a report from WHO. And they went on to say that social isolation and loneliness are forms of social disconnection. Social isolation is the objective state of having few roles, relationships, or social interactions, and constitutes the structural dimension of social disconnection. Loneliness, on the other hand, is the unpleasant or negative feeling, emotional, resulting from perceived lack of social connection, reflecting a discrepancy between the desired and the actual experience of connection. So I think those are the important distinctions. I have a training both in public health and MPH, but also training in social work. And much of my work is focused in on social isolation rather than loneliness, because I'm concerned about it, identifying the at-risk population who may have few social supports. And so rather than waiting for someone to slip through the ice to be detected, if we can somehow screen the population, we might be able to ameliorate those risk factors and perhaps design interventions that would help people when they in fact face those critical components. I look at loneliness as a topic that gets very much addressed, particularly from almost a mental health standpoint. As Roger indicated, one of the major traits of loneliness is emotional loneliness. And so it seems to have more attention there. And this is something I'll mention later in terms of measurement, but these fields kind of sprang out of different well springs with the social isolation coming out of sociology and social welfare and those kind of foci, whereas the earlier researchers in loneliness were coming out of a psychology background. So I think it's still kind of reflected in terms of the nature thereof. I know Roger and I have had many conversations about loneliness and isolation. And so I'm going to ask him to sort of tell you what I didn't tell you, because I'm sure I missed some key components, and other members of the panel as well.
Thanks, Jim. You give a really great description. I have very little to cover, but often for me, in terms, it's a little bit around measurement, but it's about, I often think about loneliness being that qualitative experience that you have to ask the person, do they feel lonely? Or questions, do they feel in tune? And social isolation is often, not always, seen about the quantitative. How many people do you feel close with? Who can you depend on in terms of an emergency? And that's back to the issue of measurement and the disciplines of how people look at the issue. But for me, it's really important, and Jim talked about public health. Definitions really matter here. And it's important to think and understand, is this person experiencing loneliness, or is this person experiencing social isolation? Because not everyone who experiences loneliness is socially isolated, and not everyone who is socially isolated experiences loneliness. So if you want to work out what's going on, you have to understand, is it loneliness, social isolation, or is it both? And it's from there that you can actually move to interventions. I know Matt and I are going to talk about interventions later on, but that's a feel for those of people who are new to the field or people working it. Just try to understand the difference between both. And when you're trying to think about solutions, which solution is most likely to be effective? Because if you think about, if you've got a network of people, but you still feel lonely, what can you do? Because so often people think, oh, it's just about meeting others. But when you understand if it's emotional or existential, it's not just about meeting others. There's something deeper we need to understand and address. So I'll hand back to Len. Thank you.
Thank you both. Magnificent job in addressing and making the distinction between the two concepts. Earlier on in my introduction for attendees, I talked about risk factors for loneliness and social isolation. So I'm going to move on to question 4, which asks, what can be done to address loneliness and social isolation? And I know that Matt has something to say about that.
Certainly. Well, and I appreciate the question because there are so many things that can be done to address social disconnection or loneliness or isolation. But I think importantly, we need to know, as mentioned earlier, is this person being afflicted by loneliness? Are they isolated, or is it a mix of both? And I believe that there are different intervention types and different opportunities to address each of those separately, because a person who is isolated might need something very different than a person who is lonely, for example. Sometimes we need to think about the structure of a person's social network or the lack thereof. Do they need to make new people? Do they need to be able to connect? Do they have sensory impairments or mobility issues where they're not able to interact? What is it that we can do to get them more individuals, more interactions relative to strengthening existing relationships? Are there interventions that help with communication or make friends and bonding experiences so that making or expanding of a network versus strengthening the existing network is extremely important based on whether the individual is experiencing loneliness or isolation? But also we need to consider preference. Just because an area, an organization, a community offers certain types of interventions, those might not be exactly what the individuals need or want. So preference is a certain a very important consideration to make sure that a person who's socially disconnected, whether they're lonely, whether they're isolated, it has to be appropriate, it has to be feasible, it has to be palatable, it has to be something desirable for them, because much like physical activity, we can't force a person to run, bike, or walk if they don't own a bicycle, live near water, or have the right shoes. And so if you want to introduce somebody into a type of intervention or a certain type of risk factor to address, it has to be something that they would do routinely. It's not a one and done, one-time solution. It has to be habitual. And oftentimes community navigation and other things can be very helpful as well. I'll stop there, Len.
Thank you, Matt. Roger, please add to what Matt had to say.
Yeah, thanks, Matt. That's been fantastic. So it's important to, when you're coming from a public health perspective, you're trying to look at, what are the issues that are affecting individuals? What are the issues that are affecting societies? And I think about addressing loneliness through a public health lens. If you think about the Freedom Health Pyramid as a useful tool to think about what interventions we can do, at the bottom of that pyramid, it's about addressing the social and economic factors that may affect loneliness, such as poverty, education, inequalities, ageism, housing. So say, for example, in housing, what we know in North America and Europe is we have a massive growth in single-person households. Now, living alone doesn't automatically mean that you're lonely. But if you want to live with others and you live alone, that may actually be causing an issue. So we have to think about the structural factors and the policy drivers that impact interventions. We've had a massive growth in commuting compared to many years ago. We're commuting longer distance to work. What does that impact upon what we can do in terms of our social relations? So that's looking at those wider social and economic factors. The next part is, if you move up a level, it's about supporting, changing the context, making healthy choices, making it easier to connect, be this within the groups, community, and our workplaces. And actually, particularly because so many of us are working from home. If this had been an event pre-COVID, we may have actually been all coming together in one place, but now we're connecting online. So we have to think about, how does that change? Then if we move up, it's about awareness raising, making sure that people know the negative impact on loneliness on our health. And Len has most certainly covered that. If we move further on up to the fourth stage of the 5 stages in the pyramid, you look at those types of programs and interventions like befriending schemes, mentoring programs, social action programs. And at the top of the pyramid are very specialist interventions. But we must look at those at the bottom of the pyramid that have the most benefit, and those, as we move further on up, that are much more focused on the individual level. I will give a plug that Len, if it's okay to say, I have a chapter coming out in a handbook on loneliness in a few months that actually outlines this here in more detail. So if anybody wants to follow up with me, please let me know and I'll share them the link. Thank you very much.
Thanks so much, Roger and Matt. I'm so glad that in fact, the social determinants of health were entered into the equation here, because one's economic status, one's cultural position, one's the degree to which folks potentially are discriminated against in communities and in society at large impacts, I think, as we know, the potential risk levels for experiencing a life of isolation and loneliness. Well done, colleagues. Let's move on to the 5th question here on this slide, and that is to better understand what the current trends are in the measurement of social isolation and loneliness. Jim, I'm going to let you start the discussion rolling.
Okay, yeah, very good. This is sort of a history that I've kind of experienced in many ways. These two topics sort of gained attention about 50 years ago. Ann Peplau at UCLA, and then Dan Russell, one of her students who subsequently was at Iowa State, worked on loneliness and measurement issues. The original UCLA loneliness scale was over 20 items. Currently, most people are using a 3-item scale. So there you see one of the trends. There's a tendency to, particularly in psychology, where you have access to college students, develop fairly lengthy measurements. But then in the real world, when you're trying to use them for practice purposes or in national surveys, it's awfully hard to ask 20 questions and be able to ask anything else. So therefore, you sort of pare it down and through some kind of psychometrics, factor analysis and the like, identify what the most important items are. And thus we have a 3-item UCLA loneliness scale. Now, one of the problems with that, of course, is that since that wasn't necessarily an organized narrowing down to the 3 items, you do have different 3-item versions of the UCLA loneliness scale. So therefore, it creates some incompatibility about how do you compare one version with another. But so I guess that's one of the trends, Len, is that we start sometimes with broad measures and then we narrow them down. And the UCLA loneliness scale was the most common measure among the 54 articles that were included in this special book. The most common social isolation measure was the scale that I had developed, the Lubben social network scale. But that actually was an outgrowth of Leonard Syme and Lisa Berkman's original work. Lisa and Len are sometimes considered to be the parents of the whole field of social epidemiology. And I was fortunate at Berkeley to be one of their students. Now, the problem where they started in their seminal work, which was published in the American Journal of Epidemiology in 1999, was a study that sort of, for the first time, showed quantitative evidence that social ties can impact on mortality rates and all kinds of health factors. And that spawned a lot of health services research that had heretofore not really looked at this particular dimension. And as a result, health service researchers looked over their data sets and realized they hadn't really measured this key construct. And we went through a period of time where we had proxies for social isolation in the measurement. And the proxies tended to be living alone or not, married or not. And as anyone who studied this field knows, those single item indicators have a lot of noise in them and don't actually properly address the construct. And one of the good things that I see in the articles that we have here is that although many of the scholars may have used a single item indicator, they used it in conjunction with a more well-developed scale. I might say that my scale really is an outgrowth of the original Berkman-Syme Social Network Index. And that was sort of better than a single item indicator. It was an index of 4 major aspects of social connectedness. They had family relationships, they had marital status, they had membership in clubs and organizations, and they had participation in religious activities. So those, from a public health standpoint, we look back now in the 1970s, 1980s, were sort of thought of as the 4 major arenas in which social connectedness kind of takes place. I'm not sure we would have come up with that same set of 4 today, but that's where it started. Now, what happened, I was at the time developing the health and psychosocial assessment forms that were being used by nurses and social workers in a large statewide case management intervention in California. And being a dutiful student, as one would be at that time, as a doctoral student, I adopted the Berkman-Syme Index and incorporated it into the battery. Unfortunately, when I got the results, I found that those two aspects of what one could call secondary group activity measurement, namely participation in clubs and organization and participation in religious activity, didn't have very much variation in the population that I was studying. The original Berkman-Syme Index was actually developed on a younger population, less 65 years of age or younger, so their dimensions of social connectedness was very much influenced by their population. So I went back and I focused in on the nature of relationship with family and friends, because they had 35 questions in their original battery. This was a large funded study, the Alameda County study, and those of you in public health know the name of Lester Breslow, who was the PI in that particular study, had developed this study, and it was well funded, and so they could ask those questions. And I was able to develop a different scoring algorithm for the nature of relationship with family and friends. And if you look at my current version of the Lubben Social Network Scale, you'll see that it really springs out of the inquiry from the Berkman-Syme Index. Now, what happened, and this is also typical of scale development, is that the original version doesn't always hold up, and so you always have to do iteration. And that was true with the loneliness scales, and it certainly was true of my scale. And I found that some of the original Berkman-Syme inquiry had double-barrel questions. That is to say, they asked two aspects in one question, so one doesn't really know which question was answered. And so I unloaded the double-barrel questions, and about 15 years ago came out with a revised version of the scale. And that's now the one that is getting most use. It was the most commonly used social isolation scale in this collection of articles that we have. And both the loneliness scale and the UCLA loneliness scale, the DeYoung loneliness scale, which was another one that was used for loneliness, and the Lubben social network scales all have well over 5,000 citations if you go into looking on different citation indexes. So that's kind of where we're at. But I'm happy that I was able to spend 45 years looking at this topic, and I'm now looking forward to people continuing to build on these constructs, to refinement, perhaps get specialized scales for our different demands, because the critical question of measurement is for what purpose? Why are we asking this question? And so my wife as a geriatric nurse, I as a geriatric social worker would have certain things in mind, but I think people who are engaged in trying to stimulate more social participation and so forth might have a different set of questions that they would want to ask. And so I'm looking forward to the next generation of measurement. And I think the final point I'd like to make is that I think it's time for us to have a conference on measurement to these two key constructs. We have documented the strong social epidemiological evidence that social isolation and loneliness kill. They have major health factors, but we could benefit by better understanding what are the core constructs and what are some of the better attempts at trying to measure those and for what purpose. I started off with a 10-item Lubben Social Network Scale, unloading the double-barrel questions. It grew to 12 items. And then because I could see the negative effect of sort of letting the market develop a modified, abbreviated version, I actually suggested a 6-item scale, and that's the one that's now getting the most use, but at least people are using the same 6 items, unlike what had happened with the UCLA loneliness scale. And so I think we can move on. I've even talked with Roger about maybe developing a 3-item version that would be appropriate for national surveys, but not sure because it has less relevance for clinical practice when you get down to 3 items and you suffer some consequence for internal consistency if you only have 3 items as opposed to 6. So there are a lot of questions there, but that kind of gives you an overview of some of the progress and some of the history. And I look forward to reading about the next work that's being done. We did have, Matthew will probably talk a little bit more about it now, is that we did have some new measures that are being developed that are included in our collection. And I look forward to how time will test those measures and how they modify accordingly.
Jim, thank you for that. You tell a good story. We appreciate that. However, I bet Matt has more to say on this matter of measurement.
I certainly do, but I'll build upon what Jim said because that's just amazing. One of the main concepts and one of the trends is about match. And Jim alluded to this, and that is you need to select the right measures for what it is that you're trying to accomplish. So, for example, we have been arguing for a long time that these large-scale surveillance systems should have the same measure so that we can consistently know across our populations what the situation is. And while some measures are great for surveillance, many of them don't have the right sensitivity to change to be used in interventions. So part of the thing is, are you having an intervention that's focused on loneliness aspects or on social connection aspects or even just general disconnection? And based on that, a lot of individuals will select brand name measures like the Lubben, like the UCLA, and use it because they don't necessarily know what else to use. And maybe that match doesn't exactly fit what their intervention is and what they're trying to accomplish. And sometimes they don't identify changes that might actually be occurring in their interventions. So I think part of the newest trend is making sure that individuals know the taxonomy, know the different constructs and understand them so that they can select the best measures for their purposes. I think another thing, and I'll speak to what Jim said, is that there are so many measures out there now. And the Foundation for Social Connection put forth a collection of almost 90 measures that are available for use in terms of social connection. Could be loneliness, isolation, social disconnection, social supports, many different constructs. Well, in doing that, there was a public outcry at community-based organizations saying, we can't ask multiple scales at the same time. We don't have the bandwidth. We don't have the ability for our staff to ask a set of 6 questions, another set of 12 questions, another set of 20 questions. We just don't have that bandwidth because we have so many other things to measure and to ask of our clients. So as such, we actually developed the Upstream Social Interaction Risk Scale, which out of 13 items has elements of 12 different scales. Because of those overlaps, it actually measures in a single scale the structure aspects, function aspects, and quality aspects of social connection. It's a little more broad. It's not measuring any of those constructs super deeply, but it certainly does give organizations an option and researchers, because it is sensitive to change, an opportunity to measure more about what's happening with their clients and what opportunities are changing with their clients based on the interventions. I think lastly, I'll just kind of stick with that, and that is a lot of organizations are really looking for practical scales that they can use. These scales in research, we want to see change because we can show the significance of our interventions and how significantly individuals benefit. But practically, organizations aren't always skilled to be able to measure pre-test, post-test, and follow up for a length of time. So they're looking for practical measures that can show the impact of their interventions, programs, and services so that they can justify the continuance of those services. They can create new partners. They can seek new funding sources. They need to be able to show these. And oftentimes a pre-post significance is not exactly what funders need to see in community settings. And I'll leave that.
Matt, Jim, thank you both. You shared with us what we needed to hear around the current state of the art of measurement. We're not there in terms of a single instrument, obviously, But that question perhaps needs to continue to be asked into the future. Is there a reduced set or even a singular way in which we can get at answering the questions that we have when we conduct research? Thank you both so much. Next slide, please. We have a second set of questions to be addressed, at least a couple of them. We're now going to move on to the question of how are social isolation and loneliness related to biological markers, cognitive decline, and what we all hear about nowadays on a regular basis, and that is Alzheimer's disease. And I know that Ted wants to share research and his perspective on this now.
Yeah, thanks, Len. So I'll break this question down to mainly two parts. So the first part will be cognitive decline and Alzheimer's disease, and then the second part will be relationship with biological markers, and then eventually tying them together in a single kind of framework. So as Len has already prefaced just now, Alzheimer's disease, cognitive decline, they are some of the most kind of devastating consequences of isolation and loneliness. And this has been shown in multiple studies, including our group's recent studies that shown that isolation, loneliness, separately and independently, they are associated with both cognitive decline and Alzheimer's disease that can be 10 to 20 years preceding the outcome. So isolation and loneliness 10 to 20 years before this outcome can actually predict the outcome already. So which is something that is shown in many studies across different countries and different research groups. So one of the more, I would say, important consensus statement that has been put out is the Lancet Commission Committee 2024, which is just last year. They put out, or I would say updated, because they have put out similar statement before, or consensus statement just 7 years or 8 years ago. And recently they updated the risk factors, modifiable risk factors for cognitive impairment or in general dementia. And isolation is one of the risk factors that is potentially modifiable, and that could account for up to about 50, to be exact, 46% of the risk factors for dementia. So isolation is one of them. And I think it accounts for about 4 to 6% alone for isolation. So which is a lot considered in the grand scheme of things, like Matt has mentioned, that, you know, in the social services and in a lot of community setting, that is a prominent risk factors as well. So that relates to how we where we are kind of post-COVID norms and as such. So COVID infection has been linked to Alzheimer's disease, increased risk, and also cognitive decline, accelerated risk of cognitive decline. So how isolation, loneliness, and the history of COVID-19 infections, they can all compound and further drive or precede cognitive impairment, cognitive decline, and Alzheimer's disease. I think it's something that is actually very pertinent, especially right now. But I think more research is needed on this front. So related to the second part of the question, the biological markers. So why they are related in terms of Alzheimer's disease is that there has been some research group associating biological markers, mostly inflammatory markers, high sensitivity C-reactive proteins. There are also inflammatory markers such as interleukin 6. So there are a bunch of markers that has been associated with loneliness and isolation. And the reason for doing that is that that's a theoretical background, not just a statistical significance, because loneliness and isolation has been proposed as stresses that can elevate stress in our body, which can cause dysregulation in multiple physiological systems. So that's one of the rationale for doing this area of investigation. But there has been recent study that show that isolation or loneliness were not associated with AD specific, so Alzheimer's specific biomarkers, but they are more broadly related to inflammatory markers and depressive symptoms. So our groups and other groups has recently shown some of the underlying mechanism connecting isolation and loneliness biomarkers as the mediators, and cognitive decline and Alzheimer's disease as the outcome. So that's the underlying so-called biological pathway that link the concepts together. But of course, more work is needed, and I'm very excited that actually more works and more groups are actually diving into this area of research. And thanks. Back to you, Len.
Thank you so much, Ted. Appreciate that. In the interest of time, I'm going to move us to question 9 on the slide, which asks, in what areas of social isolation and loneliness do we particularly need more research? And I'm going to let Roger get us underway with this discussion.
Thanks, Len. If we reflect back on the articles in your presentation, Len, one of the things that you highlighted was actually the high number of quantitative survey-based papers and the countries that were covered and not covered. And I think that's a starting point. I think we need to encourage more qualitative researchers to think about research in loneliness and social isolation, or even a triangulated where you include both qualitative and quantitative approaches. So there's the and not just one-off studies, but those over a period of time from a qualitative, longitudinal studies from a qualitative perspective would be really, really useful. Another issue is, Len, in your presentation, you talked about risk factors, and if you go to any talk, you'll hear about risk factors. But what we don't really unpack enough in the research is to understand, do we agree about these risk factors? Are all risk factors of equal importance? Are some of them triggers that knock on to the other risk factors? So I think we need to unpack that a little bit more in terms of our future research. So often, again, we focus on lonely individuals, and much of our research are on lonely individuals and vulnerable groups. Important that it is, but we must think about the impact of place and geography in terms of how that impacts the work that needs to be done. Because if you think about policies and services, they're usually at the macro level, and so much of our research that is undertaken is at the micro level. So we need to focus out much more on those macro and meso factors and to think about that. Like, say, for example, how does environment and place impact loneliness and social isolation levels? What's the importance of green spaces? And Len, you mentioned the social determinants. Let's look at issues around those social, economic, physical factors that impact upon loneliness and social isolation, or even life events, like, say, for example, becoming a carer, retiring. What does that mean? We really need, there's such a breadth, but often the research on loneliness is in narrow areas with the narrow same groups, rather than helping us understand those wider groups that are impacted. You touched on technology. We really genuinely need to understand both the negative and the positive impact that technology has on loneliness and social isolation, and for who and why. The subject area that I come from, we don't often look at what impact does personality have on loneliness and social isolation, because we look at the structure level. So those are the range of areas that you can actually think about. For anybody who wants to get into this field, there is enough to research for everyone. And the great thing of why, when you hear Jim talking about 45 years working in this field, it's because as an area, you learn all the time. It's an area that just when you think you understand, it challenges you to think, well, I may need to look at that slightly differently. So I would encourage researchers who are new to this field to look at the areas that are underdeveloped, or there's a lack of literature, and think about how they can use their skill sets to that. Particularly for those who are interested in older people, If you come along to the Gerontological Society of America Loneliness and Social Isolation Interest Group, you're going to probably meet, you definitely will meet Jim and I, because we're the co-conveners, but you'll meet Matt, Ted, Len. Those are the type of people that come along, and we're very passionate about these areas, and we want to encourage robust, relevant research that I think Matt touched on it. We need to understand the why we're doing it before we get into the who and the how. So I think that's really, really important. What do we want to find out? So Matthew, that's over to you. I think I've left you still plenty to cover about what should be researched.
Well, I will keep this brief because so many of my points, I think Roger very eloquently placed, but 2 points that I would make where I believe there's future need for research. One is we in our communities and societies have many different interventions, programs, services that are out in the community, whether they be for chronic disease prevention or management, whether they be for physical activity or fall prevention. Well, what are the indirect benefits? Can these types of interventions, based on their structure, convening individuals over a series of time for a collective purpose, actually have social connection benefits? So I've been working in social connection into many of my initiatives, even though that's not the exact reason the programs, the services were actually created. So I believe there's more to learn about those. And then in the same vein, we oftentimes want to research whether or not our program, our service is effective, but life is busier than that. Life, individuals go to multiple places oftentimes for their lives and for their connections. So what are the benefits of sequential program or service use, or even concurrent program and service use? And is that a additive or even multiplicative effect over time?
Matt, Roger, thank you so much. You've really raised all of the, as far as I'm concerned, virtually all of the significant questions that need to be asked in terms of the directions for future research. Well done, indeed. Next slide, please. Attendees, we have, like a well-oiled machine, been right on target in terms of timing and have reached the end of this webinar. This slide shares the names and email addresses of today's webinar panelists. We encourage you to contact any and all of us with further questions. We would be delighted to respond to them and do what we can to ensure that you are well informed on the topics presented today that we feel so deeply about. The last slide, please. The last slide you will see includes information on how to access our editorial. And let me tell you that the ebook itself is expected to be available to the public in open access format in the very near future, probably within a month's time. So be on the lookout for that. And so I bring now this session to a close with thanks to Frontiers, to my fellow co-editors on this project, and thanks to you, the attendees, for joining us today. Take care of yourselves.
Jim, did you want to add something?
Yeah, I was unable to load reference in the chat section, but it's included in the editorial that Leonard has in the last slide. So you can check there. Unfortunately, my neighbor just started construction, so I better go on mute. It just happened in the last 5 minutes, so bear with me. You take care, and it's been very good. Thank you, colleagues. It's good to see you. I hope to see all of you at TSA next fall.
And thank you so much to the panel of speakers for this inspiring discussion. I will be sending along the presentation, and I will get in touch with the organizers whether they will be uploading the recording of this webinar onto their website. Thank you so much for being here today.
Thank you, Amy. Thank you, everybody.
Thank you.